a while back, I was a nurse practitioner with a community center, a community living center that had assisted living, nursing home, the whole gamut, even people living in the community in their own homes. And I was doing my rounds on my caseload, and the staff and this daughter of, I'll call him Carlos. Carlos was an 82-year-old Hispanic widower who lived in an apartment by himself in assisted living. You know, Carlos was a force to be reckoned with. He was active. He was joyful. He never met a stranger. He was just so much fun to be around, and he organized a lot of the activities, not only at the ALF, but in the nursing home as well, and he still was involved with his community. So I went and saw him, and so the staff and the daughter reported that he started feeling fatigued a couple of weeks ago, and it was starting to have orthopnea at night and some peripheral edema. And walking in the room, you know, from the door, I could already tell this was congestive heart failure, acute congestive heart failure. But also was exacerbated his long-term depression diagnosis. A couple of years, actually about a year and a half before I saw him at this time, we had weaned him off his antidepressant. He really was doing well, didn't want to be back on his antidepressant, but the congestive heart failure exacerbated some of his symptoms. He was antisocial, was anhedonial, and just did not participate in the activities that he used to. First of all, he was exhausted, but also you could tell some of that depression symptoms were back. And so we treated the heart failure. We also, in conjunction, treated the depression. We did not put him back on his antidepressant right away because he and the family didn't want that. So we went with supportive therapy by the family, constant attention and engagement with the family visiting. He had a huge support system of family, and that they could come, bring food to him, and really be with him while he struggled through this. And then we also did cognitive behavioral therapy, which worked really well for him. A mental health nurse practitioner did that for us. And he got better. He got better both cardiac and mental health, and he did not go back on his antidepressant. But I share this story because it really kind of points out the intersection between cardiovascular disease and mood disorders or psychiatric mental health disorders, and that's the purpose of our talk. Now, I'm preaching to the choir here as it relates to, we all know the population is getting older, right? We know that America's getting older and the world is getting older. We all know the statistic that 10,000 of us baby boomers are turning 65 years or older every day. And so that's a growing population. And for the first time in history, older adults are projected to outnumber children by 2034. So adults go up, number of children go down. First time in history. So we're getting older. We're getting older, we're living longer, and we're living with chronic diseases for more time as well. So cardiovascular risk is a age-related risk, right? Just because their cardiac output decreases, the elasticity of the vessels decrease, as well as some individuals, their life's choices that they've made over decades has also impacted their cardiovascular risk as well. CV is the most common disease. It's the cardiovascular heart disease is the #1 killer of individuals in America. And it accounts for a significant amount of comorbidities as well as functional limitations and inactivity. For mental disorders perspective with aging, we suspect that there's different numbers, but most people are settling around 15 to 25% of older adults experience mental health disorders. Most common are the cognitives, as well as mood disorder and anxiety, but we also are having schizophrenias those with schizophrenia living longer, those with bipolar living longer. And we also know that the highest risk of completed suicide is with older men. And 65 to 80% of nursing home residents have some form of cognitive disorder or mental health disorder, and we know, and about 1/3, I think we're getting better at this, but about 1/3 of older adults, especially in the community, never receive services for mental health. So the relationship between cardiovascular and psychiatric disorders is complex, but it's also bidirectional. The risk of cardiovascular disease increases in tandem with psych mental health disorders, and mortality increases for older adults who have both psychiatric disorders with a comorbid cardiovascular disorder. So that kind of sets the stage for what we're going to talk for the rest of the talk. I'm going to turn it over to Dr. Tammy Arms.
Hello, everybody. My name is Dr. Tammy Arms. I am a professor at the University of North Carolina, Wilmington, and I am privileged to be here, part of the Geropsych SIG. Where do I hit this? Okay. So I'm going to talk to you about the medications, specifically psychotropic medications. And so you've probably heard, or you already know this, that a lot of the psychotropic medications will prolong the QT interval, meaning that it can lead to symptomatic bradycardia, possible sudden death, and that's not good, right? And a lot of our psychotropic medications can cause orthostatic hypotension. They're very highly anticholinergic. Some of the newer medicines, not as much, but anticholinergic medications are just not good for our older adults, and they have compounding effects. So the more medications that are anticholinergic, the more side effects that they're going to have from that. And on the flip side, some of the psychotropic medications can actually cause hypertension rather than the hypotension. A lot of them cause cardiotoxicity, cardiac arrhythmias, and then of course our whole atypical antipsychotic group can cause metabolic syndrome, and older adults are just more sensitive. So our antidepressants, I just wanted to mention a few of these. Max dose of Celexa or citalopram is 20 milligrams in the older adult, and that is due to the QT prolongation. However, what is not commonly known yet is escitalopram or Lexapro is actually showing worse QT prolongation than citalopram is just recently. So there is the possibility of a decreased dosing regimen being recommended for older adults coming out on that. So just stay tuned. Your SNRIs or your serotonin norepinephrine reuptake inhibitors, this is your duloxetine, your venlafaxine, and your Pristiq. First of all, venlafaxine is a prodrug. A lot of people are not aware of that. So make sure that if you're going to put an older adult on that you really do know that they are going to be able to metabolize that, because a lot of times they cannot metabolize that correctly. And then secondly, just make sure that if you put somebody on it, that they're going to be able to tolerate the withdrawal symptoms if they have to come off of it. Venlafaxine is a very difficult psychotropic medication to come off of, but it's a great medication for the right person. The other thing about your SNRIs is that they can cause elevation in blood pressure. For some of our patients, that's not a bad thing. And then for some of our patients, we might just need to bump up the antihypertensive agent, talking with a primary care provider, or if you're both, board certified in both, and you can do it, just make sure that you're monitoring that blood pressure. Your tricyclic antidepressants, of course, have that QT prolongation. They're anticholinergic. More than anything, though, they're fatal in overdose. And I'm talking, they can be fatal in the lowest dose of just 7 days. So I actually had a person who was on doxapen 10 milligrams a day. She came back into the office after 2 weeks of starting this medication. She just wasn't feeling right. She wasn't breathing as easily, just not as energetic. I did an EKG. Her heart rate was 43, and she had no cardiac symptoms prior to that. So just make sure that you're really monitoring. If you've got an older adult on a TCA, make sure you're monitoring those EKGs. And then just make sure also that they're not having any suicidal ideation, because 7 days of a TCA can be fatal.